The golden hour, why every second counts in a stroke emergency. The clock on the kitchen wall read 7:23 a.m. when Jennifer noticed her husband Tom struggling with his coffee mug. His right hand trembled, then went limp, sending ceramic and hot coffee crashing to the floor. As she rushed to help, she saw the left side of his face drooping, his attempts to speak producing only garbled sounds. In that moment, Jennifer faced a choice that would determine whether Tom would walk his daughter down the aisle next month or spend the rest of his life in a wheelchair. She could clean up the mess, help him to the couch, and wait to see if he felt better, or she could recognize these signs for what they were and call 911 immediately. Jennifer chose to act. That decision, made in seconds, saved Tom's life and preserved his ability to live independently. The difference between recovery and permanent disability came down to one critical factor: time. Every minute, nearly 2 million brain cells die during a stroke. This staggering number translates to the brain aging 3.6 years each hour without treatment. In the time it takes to watch a movie, an untreated stroke can cause decades of brain aging. Yet despite these dire statistics, studies reveal that the average stroke patient waits over 4 hours before seeking medical help. This delay, often born from uncertainty, denial, or lack of knowledge, transforms treatable medical emergencies into life-altering disabilities or death. The concept of the golden hour in stroke care parallels its use in trauma medicine, representing the critical window when medical intervention can mean the difference between full recovery and devastating outcomes. However, with stroke, the window is even narrower. While trauma patients might have an hour, stroke patients often have minutes. The most effective treatments must be administered within 3 to 4.5 hours of symptom onset, with better outcomes associated with earlier treatment. Every second of delay closes doors to treatment options and diminishes the chances of meaningful recovery. Understanding why time matters so critically in stroke requires grasping what happens in the brain during these events. When a blood clot blocks an artery or a blood vessel ruptures, brain tissue in the affected area immediately begins to suffer from lack of oxygen and nutrients. Unlike other organs that might tolerate brief interruptions in blood supply, brain tissue is exquisitely sensitive. Within seconds of blood flow cessation, brain cells begin a cascade of destruction that spreads outward from the initial injury site like ripples in a pond. The tragedy of stroke lies not just in its occurrence but in the knowledge that modern medicine possesses powerful tools to stop and even reverse this damage, if only patients arrive in time. Clot-busting medications can dissolve blockages and restore blood flow. Advanced procedures can physically remove clots from brain arteries. Surgical interventions can stop bleeding and relieve pressure. These treatments work miracles when administered promptly but become useless or even harmful when delayed. Yet the path from symptom onset to treatment is fraught with obstacles. Recognition poses the first challenge, as stroke symptoms can be subtle or mistaken for other conditions. Transportation delays add precious minutes. Hospital evaluation and imaging take time. Each step, while necessary, eats away at the golden hour. Understanding these challenges and how to overcome them empowers individuals to navigate the emergency system effectively when every second counts. The human cost of delayed stroke treatment extends far beyond statistics. Families watch loved ones lose the ability to speak, walk, or care for themselves, knowing that earlier treatment might have prevented these outcomes. Healthcare providers experience the frustration of having life-saving treatments available but being unable to use them because the therapeutic window has closed. Society bears the burden of long-term care costs that could have been avoided with prompt treatment. This article explores the critical importance of time in stroke emergencies from multiple angles. We will dissect what happens in the brain during each phase of stroke, examine the treatments available within different time windows, identify barriers to rapid treatment, and provide practical strategies for overcoming these obstacles. Most importantly, we will empower readers with the knowledge and tools to act decisively when confronted with stroke symptoms, whether in themselves or others. The stakes could not be higher. Stroke remains a leading cause of death and the primary cause of long-term disability worldwide. Every 40 seconds, someone in the United States experiences a stroke. Every 4 minutes, someone dies from one. Behind each statistic is a person whose life hung in the balance during their golden hour. The difference between those who recover and those who do not often comes down to how quickly they receive treatment. Knowledge truly becomes power when facing stroke. Understanding the signs, knowing the urgency, and being prepared to act can transform you into a lifesaver. Whether you are reading this for yourself, your family, or your community, the information that follows could one day make the difference between tragedy and recovery. Time is brain, as neurologists say, and understanding this principle deeply enough to act on it when needed is perhaps one of the most valuable pieces of health knowledge anyone can possess. The journey through stroke's golden hour begins with recognition and ends with recovery or its absence. Between these points lie critical decisions, each with the power to alter outcomes dramatically. By understanding this journey, we can better navigate it when the stakes are highest. The clock starts ticking the moment symptoms begin. What happens next depends on knowledge, preparation, and the courage to act when every second counts. The brain under attack. What happens during a stroke? To understand why time is so critical during a stroke, we must first comprehend the devastating cascade of events unfolding in the brain from the moment blood flow stops. This biological catastrophe progresses with frightening speed, transforming healthy brain tissue into damaged or dead cells within minutes. The process differs somewhat between ischemic strokes, caused by clots, and hemorrhagic strokes, caused by bleeding, but both share the common thread of rapid, progressive damage that only swift intervention can halt. When an ischemic stroke begins, a blood clot lodges in a brain artery, creating an immediate crisis in the tissue that artery supplies. Within seconds, neurons in the affected area stop their normal electrical activity. The sodium-potassium pumps that maintain cellular function fail without oxygen and glucose. Cells begin swelling as fluid balance disrupts. This core area of severe ischemia, called the infarct core, suffers irreversible damage within minutes. No current medical treatment can resurrect these cells once they die. Surrounding the infarct core lies a region called the penumbra, where blood flow is reduced but not completely absent. These cells teeter on the brink of death, their fate hanging in the balance. The penumbra represents both hope and urgency in stroke treatment. With rapid restoration of blood flow, penumbral tissue can recover completely. Without intervention, the infarct core expands into the penumbra like a spreading wildfire, claiming more brain tissue with each passing minute. The concept of the penumbra revolutionized stroke treatment by revealing that significant amounts of brain tissue remain salvageable for hours after symptom onset. However, this window of opportunity shrinks rapidly. Studies using advanced brain imaging show the penumbra diminishing measurably with each hour of delayed treatment. What might be a small stroke if treated within an hour can become a massive stroke if treatment waits until hour 4 or 5. Hemorrhagic strokes create a different but equally urgent crisis. When a blood vessel ruptures, blood pours into brain tissue or the spaces surrounding the brain. This blood acts as a toxin, directly damaging brain cells and triggering inflammation. The accumulating blood also creates pressure, compressing healthy brain tissue and potentially cutting off its blood supply. Unlike ischemic strokes where the damage spreads outward from a blocked vessel, hemorrhagic strokes can affect distant brain areas through pressure effects. The brain's response to stroke involves more than just the immediately affected tissue. Within minutes, inflammatory cascades begin, with immune cells rushing to the damaged area. While inflammation serves protective purposes, it also contributes to additional damage. Blood-brain barrier breakdown allows fluid and proteins to leak into brain tissue, causing swelling. This cerebral edema can be as dangerous as the initial stroke, potentially causing herniation where brain tissue is pushed into spaces it should not occupy. Metabolic changes compound the crisis. Deprived of oxygen, cells switch to anaerobic metabolism, producing lactic acid that further damages tissue. Calcium floods into cells, triggering destructive enzymes. Free radicals form, attacking cellular structures. Excitatory neurotransmitters release in toxic amounts, overstimulating and killing neighboring neurons. This process, called excitotoxicity, means that stroke damage extends beyond areas directly deprived of blood flow. The speed of neuronal death during stroke is breathtaking and sobering. Researchers calculate that the typical stroke patient loses 1.9 million neurons each minute. To put this in perspective, the normal aging process claims about 9,000 neurons daily. A stroke compressed 200 days of normal aging into every minute. During an average shower, a stroke patient could lose as many neurons as would normally die in a decade. Different brain regions show varying vulnerability to stroke damage. The hippocampus, crucial for memory formation, suffers damage quickly. Motor cortex cells controlling movement prove relatively resilient but still succumb without prompt treatment. Language areas can be devastated within the first hour. The variability in regional susceptibility explains why stroke symptoms differ among patients and why rapid treatment is essential regardless of which symptoms appear. The concept of collateral circulation offers both hope and urgency in stroke treatment. The brain possesses backup blood vessels that can partially supply areas when primary vessels block. Robust collaterals can buy precious time, keeping the penumbra viable longer. However, collateral flow is rarely sufficient to prevent damage indefinitely. These backup systems represent a temporary reprieve, not a solution, emphasizing why rapid treatment remains critical even when symptoms seem stable. Time-dependent changes in the blood-brain barrier create additional treatment challenges. This normally tight barrier prevents medications and toxins from entering brain tissue. During stroke, the barrier becomes increasingly permeable. While this can aid drug delivery, it also increases bleeding risk from clot-busting medications. The optimal treatment window balances maximum benefit with acceptable risk, a calculation that shifts unfavorably with each passing hour. Understanding cellular death mechanisms in stroke has led to the concept of neuroprotection, attempting to shield brain cells from damage while blood flow is restored. Despite decades of research, no neuroprotective drug has proven effective in humans, partly because the window for protection is so narrow. By the time most patients reach treatment, cascades of damage are too advanced for simple protection. This failure underscores why rapid restoration of blood flow remains the only proven strategy. The brain's energy demands help explain its vulnerability to stroke. While comprising only 2% of body weight, the brain consumes 20% of the body's oxygen and glucose. This voracious appetite means even brief interruptions in supply cause crisis. Unlike muscles that can function anaerobically for extended periods, brain tissue tolerates no compromise in its energy supply. This metabolic inflexibility drives the urgency of stroke treatment. Recovery potential directly correlates with treatment speed. Brain imaging studies show that patients treated within the first hour often have minimal or no visible damage on follow-up scans. Those treated at 2 hours show small infarcts. By 3 to 4 hours, substantial damage is usually evident. Beyond 6 hours, the damage is typically extensive and irreversible. These imaging findings translate directly to functional outcomes, with earlier treatment predicting better recovery. The plasticity of surviving brain tissue offers hope but cannot replace lost neurons. After stroke, surrounding brain areas can sometimes assume functions of damaged regions through intensive rehabilitation. However, this reorganization works best when damage is limited. Massive strokes overwhelm the brain's compensatory abilities. Minimizing initial damage through rapid treatment provides the foundation for successful rehabilitation and recovery. Advances in brain imaging allow real-time visualization of stroke progression. Perfusion imaging shows blood flow to different brain regions. Diffusion-weighted imaging reveals tissue viability. These tools help physicians identify salvageable tissue even hours after symptom onset in some patients. However, obtaining and interpreting these images takes precious time, creating a paradox where the tools to guide treatment consume the very minutes needed for that treatment. The molecular biology of stroke reveals why certain treatments work only within specific time windows. Clot-busting medications like tissue plasminogen activator work by dissolving fibrin, the protein mesh holding clots together. However, clots mature over time, becoming denser and more resistant to dissolution. Fresh clots dissolve readily, while older clots resist even powerful medications. This biological reality creates a hard deadline for certain treatments. The concept of reperfusion injury adds another layer of complexity to stroke treatment. When blood flow is restored to damaged tissue, the sudden influx of oxygen can paradoxically cause additional damage through free radical formation. This phenomenon means that the method and timing of reperfusion matter greatly. Gradual, controlled reperfusion causes less injury than sudden restoration. However, the urgency of treatment usually precludes such fine control. Research into stroke pathophysiology continues, revealing new time-dependent processes. Recent studies show that the brain's lymphatic system, which clears waste products, shuts down during stroke. This cessation contributes to toxic accumulation and swelling. Other research reveals time-dependent changes in gene expression, with protective genes activating early but becoming overwhelmed as stroke progresses. Each discovery reinforces the critical importance of rapid treatment. The inflammatory response to stroke evolves over hours and days, but its foundation is laid in the first minutes. Initial inflammation can be beneficial, clearing debris and promoting healing. However, excessive or prolonged inflammation causes secondary damage. Anti-inflammatory treatments show promise but must be carefully timed. Too early, and they might interfere with beneficial inflammation. Too late, and the damage is done. This timing challenge exemplifies why stroke treatment requires such precision. Understanding what happens during stroke's golden hour transforms abstract urgency into concrete comprehension. Each minute of delay allows millions of neurons to die, functional networks to collapse, and treatment options to narrow. This knowledge should inspire immediate action when stroke symptoms appear. The brain under attack cannot wait for convenient timing or certainty. It needs help now, measured not in hours but in minutes. The biology is unforgiving, but knowledge of this biology empowers us to act with appropriate urgency. The race against time, treatment windows and options. Modern medicine's arsenal against stroke is powerful but time-limited. Each treatment option comes with a specific window of opportunity, beyond which it becomes ineffective or dangerous. Understanding these windows and the treatments available within them illuminates why the race against time is so critical and what stakes ride on rapid medical attention. The evolution of stroke treatment over recent decades has expanded options and extended windows, but time remains the enemy that no technology has conquered. The first and most widely available treatment for ischemic stroke is intravenous tissue plasminogen activator, commonly known as TPA or Alteplase. This clot-busting medication, delivered through a simple 4, can dissolve blood clots and restore blood flow to threatened brain tissue. The FDA-approved window for TPA is within 3 hours of symptom onset, though selected patients may benefit up to 4.5 hours. This treatment, when given early, can completely reverse stroke symptoms in some patients, earning it the nickname "clot buster" among medical professionals. The effectiveness of TPA dramatically decreases with time. Studies show that patients treated within 90 minutes of symptom onset are 3 times more likely to recover with minimal or no disability compared to those treated closer to the 3-hour deadline. For every 15-minute delay in TPA administration, outcomes measurably worsen. This stark time dependency means that the difference between walking out of the hospital and leaving in a wheelchair might be the time spent debating whether symptoms are serious enough to call 911. Beyond the standard window, TPA becomes increasingly dangerous. As brain tissue dies and blood vessels weaken, the risk of catastrophic bleeding rises. The same medication that saves lives in the first 3 hours can cause fatal brain hemorrhages when given too late. This transformation from cure to potential killer exemplifies why stroke treatment cannot be delayed. The body's biology creates non-negotiable deadlines that no amount of hoping or wishing can extend. Mechanical thrombectomy represents a revolution in stroke treatment, extending the treatment window for select patients with large vessel occlusions. This procedure involves threading a catheter through blood vessels to the brain and physically removing the clot. Specialized devices can grab, aspirate, or break up clots that resist medication. The standard window for thrombectomy extends to 6 hours from symptom onset, with selected patients benefiting up to 24 hours based on advanced imaging. The extended window for thrombectomy might suggest less urgency, but this would be a dangerous misconception. Outcomes remain strongly time-dependent. Patients undergoing thrombectomy within 2 hours of onset have significantly better outcomes than those treated at 6 hours. Each hour of delay reduces the probability of functional independence by approximately 10%. The extended window provides hope for patients who cannot receive earlier treatment, not an excuse for delay. The concept of wake-up stroke illustrates both progress and limitations in extending treatment windows. Many strokes occur during sleep, with patients awakening to discover symptoms. Without knowing exact onset time, these patients were historically excluded from time-based treatments. Advanced imaging can now identify some wake-up stroke patients who might benefit from treatment, but this requires sophisticated technology and expertise not available everywhere. Even with these advances, outcomes remain better with witness strokes treated immediately. Hemorrhagic strokes face different but equally urgent treatment considerations. While no equivalent to TPA exists for bleeding strokes, rapid blood pressure control can limit hematoma expansion. Studies show that aggressive blood pressure reduction within the first hour can significantly reduce bleeding and improve outcomes. Surgical options, including minimally invasive clot evacuation, show promise but must be performed quickly before increased pressure causes irreversible damage. The development of stroke systems of care recognizes that treatment begins before hospital arrival. Emergency medical services protocols now include stroke screening tools and pre-notification systems. Paramedics can alert hospitals while en route, allowing stroke teams to prepare. Some regions employ mobile stroke units, essentially ambulances with CT scanners and stroke specialists, bringing treatment to patients. These innovations shave precious minutes off treatment times but require recognition and activation through 911 calls. Neuroprotective strategies represent the holy grail of stroke treatment, theoretically buying time for definitive treatment. Despite testing hundreds of compounds, no neuroprotective drug has proven effective in humans. The failure of neuroprotection reinforces that rapid reperfusion remains the only proven strategy. Time spent pursuing unproven treatments is time stolen from proven therapies. This reality makes public education about proven treatments and their time windows crucial. The door-to-needle time metric measures how quickly hospitals can deliver TPA after patient arrival. Leading stroke centers achieve door-to-needle times under 30 minutes through streamlined protocols. This involves immediate triage, rapid CT scanning, point-of-care laboratory testing, and pre-mixed TPA ready for administration. Every minute saved in door-to-needle time translates to measurable improvements in patient outcomes. Hospitals continuously refine processes to shave seconds off treatment times. Telemedicine extends stroke expertise to remote locations, ensuring that geography does not determine destiny. Through video connections, stroke specialists can examine patients, review imaging, and guide treatment in hospitals lacking on-site expertise. This technology has dramatically improved rural stroke care, but it cannot overcome the fundamental time limitations of stroke treatment. The best telemedicine connection cannot replace time lost to delayed recognition or transportation. The concept of drip and ship illustrates the complexity of modern stroke care. Smaller hospitals can begin TPA and then transfer patients to comprehensive stroke centers for advanced treatments like thrombectomy. This approach maximizes the benefit of early treatment while ensuring access to advanced care. However, coordination between facilities takes time, and delays in any step can push patients beyond treatment windows. Smooth execution requires practiced protocols and excellent communication. Imaging evolution has refined patient selection for treatment, but at a time cost. Basic CT scans rule out hemorrhage and enable TPA decisions within minutes. Advanced imaging like CT perfusion or MR imaging can identify salvageable tissue in extended time windows but takes longer to acquire and interpret. The tension between gathering more information and treating faster exemplifies the difficult decisions in stroke care. Perfect information arriving too late helps no one. The expansion of thrombectomy capabilities cannot keep pace with demand. While the procedure's effectiveness has led to rapid adoption, not every hospital can offer it. The procedure requires specialized equipment, trained neurointerventionalists, and support staff. Patients needing thrombectomy might require transfer to distant centers, consuming precious time. Geographic disparities in access to advanced stroke care create inequities that systematic planning must address. Quality improvement initiatives in stroke care focus relentlessly on time metrics. Hospitals track door-to-needle times, door-to-groin puncture times for thrombectomy, and overall treatment rates. Public reporting of these metrics creates accountability and drives improvement. Leading centers share best practices, spreading innovations that save minutes. The stroke care community's obsession with time reflects the biological reality that faster treatment means better outcomes. The economics of stroke treatment reinforce the importance of rapid care. Early treatment not only improves outcomes but reduces long-term care costs. A patient who walks out of the hospital after prompt TPA costs the healthcare system far less than one requiring years of nursing home care due to treatment delays. Insurance coverage universally supports proven acute treatments, recognizing their cost-effectiveness. The economic argument adds to the moral imperative for rapid treatment. Research continues pushing treatment boundaries, but time remains unconquered. Trials explore extending TPA windows, improving clot-busting medications, and developing new thrombectomy devices. Combination therapies might squeeze additional benefit from existing treatments. However, no breakthrough has eliminated the fundamental time dependency of stroke treatment. Future advances might extend windows or improve outcomes within them, but the race against time will continue. The message from treatment options and windows is clear: stroke is a medical emergency requiring immediate action. The most advanced treatments in the world cannot help patients who arrive too late. Every proven therapy works better when delivered earlier. The window of opportunity opens with symptom onset and inexorably closes with each passing minute. Understanding these windows should motivate immediate action when stroke symptoms appear. In the race against time, there are no prizes for second place. Breaking down barriers, why people delay and how to overcome it. Despite the clear urgency of stroke treatment, the average patient waits hours before seeking help. This deadly delay stems from multiple barriers, each representing a link in a chain that must be broken to save lives and preserve function. Understanding these barriers is the first step toward overcoming them. Each minute of delay has a reason, and each reason has a solution. By systematically addressing why people wait, we can compress the time from symptom onset to treatment and dramatically improve outcomes. The first and often most significant barrier is recognition. Stroke symptoms can be subtle, intermittent, or easily attributed to less serious causes. Unlike the crushing chest pain of a heart attack, stroke might announce itself with mild weakness, slight speech difficulty, or subtle visual changes. People rationalize these symptoms as fatigue, stress, or normal aging. The brain's own impairment during stroke can further cloud judgment, making self-recognition even more challenging. Denial represents a powerful psychological barrier to seeking help. Acknowledging stroke symptoms means confronting mortality and the possibility of permanent disability. The mind naturally resists such threatening information. People tell themselves they will feel better after resting, that symptoms will pass, or that they are overreacting. This denial is not stupidity but a normal human response to frightening situations. Overcoming denial requires both education before stroke occurs and clear protocols that bypass psychological resistance. The wait-and-see approach kills brain cells by the millions. Many people experiencing stroke symptoms decide to wait an hour to see if they improve. When symptoms persist, they wait another hour. This incremental delay, each seeming reasonable in isolation, accumulates to push patients beyond treatment windows. The decision to wait and see might feel prudent but represents one of the most dangerous choices in stroke response. Fear of embarrassment prevents many from calling 911. People worry about causing a fuss if symptoms turn out to be nothing serious. They imagine the embarrassment of ambulances arriving for a false alarm. This social anxiety trades potential embarrassment for actual brain damage. Healthcare providers would rather evaluate 1,000 worried well patients than miss one stroke. The embarrassment of overreacting pales compared to the regret of underreacting too late. Economic concerns create barriers, particularly for the uninsured or underinsured. People fear ambulance bills, emergency room costs, and lost wages from missing work. These financial worries lead to dangerous delays as people try home remedies or wait for regular clinic appointments. While financial concerns are real, stroke treatment delays convert manageable acute care costs into potentially catastrophic long-term care expenses. Cultural factors influence how people respond to stroke symptoms. Some cultures emphasize stoicism, viewing medical help seeking as weakness. Others rely heavily on traditional remedies before considering Western medicine. Language barriers can make calling 911 intimidating for non-English speakers. Effective stroke response must acknowledge and address these cultural factors through community-specific education and culturally competent emergency services. Geographic isolation creates unique challenges in rural areas. When the nearest hospital is hours away, people might delay longer, hoping symptoms resolve rather than undertaking difficult travel. Limited ambulance availability might mean long waits for transport. These geographic realities require innovative solutions like telemedicine and air transport, but they start with recognition that triggers the emergency response system. The weekend effect shows how timing influences delay. Strokes occurring on weekends or holidays face additional barriers as people avoid disrupting family gatherings or wait for regular doctors' offices to open. The brain does not respect social calendars. Stroke systems of care must provide consistent rapid response regardless of when symptoms occur. Medication misunderstanding contributes to delay when people attempt self-treatment. Taking aspirin, blood pressure medication, or other drugs while waiting to see if symptoms improve wastes precious time. While aspirin might help in specific circumstances, it cannot substitute for emergency evaluation and treatment. Home remedies delay proven treatments and might even cause harm if bleeding rather than clotting causes the stroke. The role of bystanders often determines response speed. Many stroke patients cannot recognize their own symptoms or call for help due to confusion or speech problems. Family members, co-workers, or even strangers become the critical link to treatment. However, bystanders face their own barriers, including uncertainty about symptom significance and reluctance to override the affected person's wishes. Empowering bystanders to act saves lives. Previous false alarms can paradoxically increase delay. People who have experienced transient ischemic attacks or stroke mimics might dismiss new symptoms based on past experiences. This boy who cried wolf phenomenon leads to tragic delays when real strokes occur. Each potential stroke deserves immediate evaluation regardless of past experiences. The one-time symptoms are dismissed might be the time that determines disability or death. System barriers compound individual delays. Long emergency department waits for non-stroke complaints discourage people from seeking emergency care. Complex hospital navigation, insurance requirements, and past negative healthcare experiences all contribute to delay. Healthcare systems must examine and address these barriers to ensure stroke patients receive rapid treatment regardless of past experiences or system complexity. Technology offers solutions to many barriers. Smartphone apps can help recognize stroke symptoms and directly connect to 911. Video calls allow remote assessment by healthcare providers. GPS tracking ensures ambulances find patients quickly. Automated reminder systems can prompt medication compliance and regular checkups. Leveraging technology to overcome traditional barriers represents a frontier in stroke care improvement. Public education campaigns show mixed results in reducing delay. Simple messages like fast help recognition but must compete with deeply ingrained behaviors and beliefs. Effective education must go beyond symptom recognition to address psychological barriers, provide specific action plans, and repeatedly reinforce messages. The most effective campaigns combine mass media with community-level interventions targeting specific populations. The emergency medical services interface requires optimization. Clear protocols for 911 dispatchers to recognize stroke symptoms ensure appropriate response priority. Paramedic training in stroke recognition and severity assessment improves field triage. Pre-hospital notification allows emergency departments to prepare, saving precious minutes. Each link in the emergency response chain must be strengthened to minimize delay. Family education multiplies impact. When family members understand stroke symptoms and the importance of immediate action, they become a safety net for their loved ones. Family meetings to discuss stroke response plans, including override authority for calling 911, can save precious minutes during actual events. The investment in family education pays dividends when seconds count. Workplace interventions reach people where they spend much of their time. Training employees to recognize stroke symptoms in colleagues and establishing clear protocols for emergency response can save lives. Workplace cultures that support health-seeking behavior and do not penalize medical emergencies encourage appropriate response. Employers benefit from faster stroke recognition through reduced disability and maintained productivity. Healthcare provider education remains crucial. Primary care providers must emphasize stroke urgency during routine visits. Clear communication about when to call 911 versus scheduling appointments can prevent deadly delays. Providers should address patient-specific barriers and develop personalized stroke response plans for high-risk individuals. The message about overcoming barriers must be clear and repeated. When stroke symptoms occur, call 911 immediately. Do not drive yourself, do not wait to see if symptoms improve, do not call your doctor's office first. The only appropriate response is immediate activation of emergency services. This simple message, consistently reinforced, can overcome complex barriers through clarity and repetition. Success stories inspire appropriate action. Sharing accounts of people who acted quickly and recovered fully, contrasted with delays leading to disability, makes abstract concepts concrete. Real people with real outcomes humanize statistics and motivate behavior change. Every stroke survivor who acted quickly becomes an ambassador for rapid response. Creating a culture of urgency around stroke requires sustained effort. Just as society learned that chest pain means call 911, we must establish the same reflex for stroke symptoms. This cultural shift requires consistent messaging from healthcare providers, public health campaigns, community organizations, and stroke survivors themselves. When immediate response becomes automatic, barriers crumble before the imperative to save brain tissue. The future of barrier reduction lies in systematic approaches. Identifying community-specific barriers through research, designing targeted interventions, and measuring outcomes creates continuous improvement. Technology will play increasing roles, but human factors remain paramount. Understanding why people delay is the first step. Creating systems and cultures that promote immediate action is the goal. Every barrier overcome translates to neurons saved and disabilities prevented. The role of bystanders, becoming a stroke hero. In the critical moments when stroke strikes, heroes rarely wear capes or carry medical degrees. They are spouses recognizing subtle changes in their partners, co-workers noticing a colleague struggling with words, or strangers in public places who choose to get involved. Bystanders often determine whether stroke victims receive treatment within the golden hour or face permanent disability. Understanding how to recognize stroke and take decisive action transforms ordinary people into lifesavers. The power to save a brain, and possibly a life, lies not just with medical professionals but with anyone willing to learn and act. The unique challenge of stroke recognition is that victims often cannot help themselves. The very organ under attack is responsible for recognition, decision-making, and action. Stroke can impair judgment, cause confusion, or render victims unable to speak or move. This cruel irony means that survival often depends entirely on those nearby. A stroke victim might feel fine despite obvious symptoms or insist they do not need help while millions of brain cells die. Bystanders must be prepared to recognize what victims cannot and act when victims will not. Recognition begins with understanding stroke's varied presentations. While public education often focuses on classic symptoms like facial drooping and arm weakness, stroke can manifest in numerous ways. Sudden confusion might be the only sign. A normally articulate person struggling to find words deserves immediate attention. Someone who suddenly cannot understand simple instructions needs help. Balance problems, severe headache, or vision changes all warrant emergency response. Bystanders must think stroke when witnessing any sudden neurological change. The FAST acronym provides a simple framework for bystander action. Face drooping, arm weakness, speech difficulty, and time to call 911 captures the most common stroke presentations and appropriate response. However, bystanders should not feel limited by FAST. Any sudden brain function change deserves emergency evaluation. The consequences of overreacting to a non-stroke pale compared to underreacting to an actual stroke. When in doubt, make the call. Cultural competence in stroke recognition acknowledges that symptoms might present differently across populations. Language barriers can mask speech difficulties if bystanders do not speak the victim's language. Cultural norms about maintaining composure might lead victims to minimize symptoms. Bystanders must be sensitive to these factors while maintaining urgency about potential stroke. A person struggling in any language needs help. The psychology of bystander intervention reveals why people often fail to act during emergencies. The bystander effect, where individuals are less likely to help when others are present, can delay stroke response. Everyone assumes someone else will take charge or has more knowledge. Overcoming this effect requires specific mental preparation. Decide now that you will be the person who acts. Do not wait for others or assume someone else has called for help. Taking charge during a stroke emergency requires balancing assertiveness with compassion. Stroke victims might resist help due to confusion, embarrassment, or impaired judgment. Bystanders must be prepared to override objections kindly but firmly. Phrases like "I am concerned about you and need to call for help" or "the paramedics can check you out and make sure you are okay" provide face-saving ways to accept assistance. The goal is rapid medical evaluation, not winning arguments. The 911 call represents a critical bystander action requiring specific preparation. Tell the dispatcher immediately that you suspect stroke. Provide the exact location, including landmarks or specific addresses. Describe symptoms clearly and concisely. Follow dispatcher instructions, which might include positioning the victim or gathering medications. Stay on the line unless instructed otherwise. Your calm, clear communication sets the emergency response in motion. While awaiting emergency services, bystanders can take simple but important actions. Note the time symptoms began or were first noticed, as this information guides treatment decisions. Keep the victim comfortable but do not give food, water, or medications unless instructed by emergency services. If the victim becomes unconscious, position them on their side to prevent choking. Gather medications and medical information if readily available. These actions support rapid treatment upon medical arrival. The workplace presents unique opportunities for bystander intervention. Coworkers often notice changes before family members, spending 8 hours daily together. Establishing workplace protocols for medical emergencies, including stroke recognition training, creates prepared bystanders. Designated emergency response team members can provide leadership during crisis. Regular drills reinforce appropriate actions. The workplace that invests in emergency preparedness protects its most valuable asset, its people. Public spaces challenge bystander intervention through anonymity and uncertainty. Approaching strangers requires overcoming social norms about privacy and non-interference. However, stroke strikes regardless of location. The person struggling to speak at the grocery store or stumbling at the park needs help regardless of social conventions. A simple "Are you okay or do you need help?" can initiate life-saving intervention. Many stroke survivors owe their lives to strangers who chose involvement over indifference. Family members face unique challenges as bystanders. Recognizing stroke in loved ones can trigger denial or panic. Long-standing relationship dynamics might interfere with appropriate response. The spouse who has always minimized health concerns might resist calling 911. Family members must prepare mentally to override normal patterns during emergencies. Discussing stroke response plans during calm times establishes permission to act decisively during crisis. Children as bystanders require special consideration. Teaching age-appropriate stroke recognition empowers children to help family members. Young children can learn to call 911 and provide addresses. Teenagers can learn fast and basic first aid. Stories abound of children saving grandparents' lives by recognizing stroke symptoms learned in school. Empowering children with knowledge and permission to act creates an additional safety layer for families. Technology assists bystander response through various applications. Smartphone apps can guide stroke recognition and connect directly to emergency services. Video calls allow remote medical professionals to assess symptoms. Location sharing ensures emergency services find victims quickly. Translation apps help overcome language barriers. Bystanders should familiarize themselves with available technological tools before emergencies arise. The legal concerns that sometimes inhibit bystander action are largely unfounded. Good Samaritan laws protect those who provide reasonable assistance during emergencies. Calling 911 and providing basic comfort until help arrives carries virtually no legal risk. The legal system in Keurig.